Good morning to all ACP members. My name is Marisol Santiago Irizarry. I'm a second-year infectious diseases fellow at the VA hospital. The title of my case is Meet My New Pal. Multidrug resistant tuberculosis is in Puerto Rico. Case of a 74-year-old man with no medical conditions and poor compliance with doctor's appointments and follow-up who came to the emergency room with complaining of generalized malaise, subjective fever, cough with the upper production of yellow sputum, and chills of 1 day of evolution. At the emergency department, he was hypotensive and tachycardic. Therefore, he was treated with IV fluids and subsequently started on vasopressors and broad-spectrum antibiotic therapy was started with vancomycin and piperacillin tazobactam. On the review system, patient with 15-kilogram weight loss in the past year, denied tuberculosis exposure, recent travel, nor contact with a patient with tuberculosis. He has no known drug allergies, denied surgical history, no use of medications at home, and social history is remarkable for 30-year pack per day smoking history and chronic ethanolism. Physical examination at the emergency room was remarkable for a chronically ill appearance. No respiratory distress, no coughing, and lung auscultation was unremarkable. Chest X-ray showed a cavitation in the right upper lobe, which was confirmed by chest CT scan, which was suspicious for lung malignancy. In addition, blood cultures were positive for Acinetobacter leufei. Patient was admitted to the hospital with diagnosis of septic shock secondary to Acinetobacter leufei. Rule out tuberculosis versus lung malignancy. Bacteremia resolved during this admission, but source could not be identified. Patient was placed on airborne isolation, and 3 smears for AFP were obtained and came back negative. Patient underwent 2 bronchoscopies given the unclear diagnosis, and both bronchoalveolar lavages were negative for acid-fast bacilli, as well as no malignant cells were found. Ball samples were sent out, and DNA probe came back positive for tuberculosis, as well as a quantiferon test. CT-guided lung biopsy was performed, which demonstrated numerous acid-fast positive bacilli, which confirmed the diagnosis of active pulmonary tuberculosis. Treatment with rifampin, isoniazid, pyrazinamide, and ethambutol was initiated, and after 3 subsequent negative ASP smears, patient was discharged home. After 2 months on RIPE, molecular studies identified the Mycobacterium tuberculosis was resistant to rifampin and isoniazid, which defines what it is: a multidrug resistant tuberculosis. We started the patient on linezolid, amikacin, and imipenicillastim IV antibiotics, pyrazinamide, and isoniazid with increased dose, following the American Thoracic Society guidelines, but unfortunately, he did not tolerate the therapy. Alternatives were explored to avoid IV antibiotics, reason why cycloserine was added to the regimen, but patient developed vivid and complex visual hallucinations and had to be discontinued. A new drug regimen for treatment for MDR tuberculosis called BPAL, which stands for bedaquiline, pretomanid, and linezolid, was started, and patient completed successfully 26 weeks of treatment. Here are the doses that are recommended in the protocol. Side effects to be aware during this regimen include: for bedaquiline, we should monitor QTc for prolongation. Most common side effects of pretomanid is peripheral neuropathy, but could also prolong the QT on EKG. Where is our patient right now? He has no acute symptoms and has been gaining weight. His relatives were tested for tuberculosis and PPD were negative. Where did he get this MDR tuberculosis? Well, after questioning patient and his relatives, he spent time with his neighbor, who is originally from the Dominican Republic, which is a country known to have MDR tuberculosis. Currently, we requested a new chest CT scan and a PET CT scan for follow-up. The clinical relevance of this case is to show that multidrug-resistant tuberculosis is in Puerto Rico and that there is a new regimen for the treatment of these patients. As internists, we should be aware of new modalities of treatment that are available right now, and that we should always be aware of side effects of conventional and non-conventional therapies. It is very crucial to provide appropriate management in these cases in order to have adequate outcomes. We want to minimize patients' disabilities and, most importantly, avoid spread in the community. And here are my references. Thank you very much for this opportunity, and thank you to all ACP members.